afternoon, and I'd like to thank once again Enzo for inviting me to this fabulous conference. Every year I come, it's just wonderful. I'd like to talk to you about the dark side of DMEC. We have seen a little of the dark side on each of our surgeries. I have no disclosures relevant to this talk. The advantages of DMEC are well known: better vision, faster visual recovery, less steroids, no IOP problems, and less rejection rate than DSAIC or PK. But there is a dark side to DMEC. Let me show you the misadventures in DMEC surgery. This is a case I dug up from this is my second case I ever did. And you see I had the same problem I had yesterday. The tissue stuck in the wound. Now, I was trying to use the DSAIC technique of irrigating the tissue into the eye, and look what happens. Now in slow motion so you can feel my pain. So this is the second DMEC I ever did, and I almost never wanted to do another one. But the point I'm showing you here is that we can learn from problems we encounter. The problem is discouraging, but we can learn from that. And what I learned from this is that you cannot take the skills that you learned in DSAIC and apply them to DMEC. You have to have another skill set. And so one of the important aspects in DMEC, that's the dark side, is the tissue will always follow the fluid waves. And if you try and irrigate the tissue out of the wound, and you're opening the wound at the same time, you're going to have the tissue shoot out, as you saw in that case there. A better solution is to have the chamber very shallow, and to take a forceps and either insert the tissue and open the wound at the same time, or to take an intraocular forceps and open the wound and pull the tissue in at the same time. But remember, the tissue will always follow the fluid waves. Now, the dark side of DMEC involves known complications that present in a unique way, and unique complications that you didn't think really were possible. Well, let's look at the intraoperative dark side. You just saw one of the examples of the intraoperative dark side. And there are other aspects as well. I don't have the video on here, but one of the aspects of the dark side is that if you make the incision larger than your injector, then what will happen is if you inject the tissue, it can go into the anterior chamber, then out along the side of your injector. And we don't see that happening with DSAIC. We do see it happen with DMEC. So you have to be very careful on the size of your incision, because the dark side of DMEC is that the tissue will go around your injector if it's larger than your injector. You can have pupil size problems, and you can have trouble unfolding and setting the donor tissue due to fibrin formation. We saw a little bit of that on one of the first cases at the conference, where blood was in the anterior chamber, making the unfolding of the tissue very difficult. One other aspect of the dark side of DMEC is that there is more endothelial damage to your tissue when you receive it than there is with DSAIC. The microkeratome passing across the donor cornea causes very little endothelial damage, whereas pre-stripping or stripping the tissue intraoperatively causes more damage to the endothelium. Another aspect is to realize that we'd like to have a small pupil, but when we're doing triple procedures, we don't like to have a small pupil because it's more difficult for the cataract surgery. Our solution to that has been to use ephedrine or neosynephrine or whatever topical epinephrine to dilate the pupil and not use any cycloplegics at all. And the vast majority of the time, the pupil will stay at about 6 millimeters to allow you time to do your cataract surgery. And then when you use your acetylcholine to constrict the pupil, you can get a very tight, small pupil. If you use cycloplegics prior to your cataract surgery, you may have a more difficult time getting the pupil small. Not always, but sometimes. If you run into a situation like this intraoperatively, you might be advised to put epinephrine into the anterior chamber to make the pupil larger so you can finish your cataract surgery safely. Now, fibrin strands in the recipient anterior chamber can cause tremendous trouble opening up the graft. We've only had 6 cases at Devers out of now 600 cases where we've had fibrin strands that have occurred without bleeding in the anterior chamber. Bleeding in the anterior chamber can give you a lot of fibrin, but even without bleeding, you can sometimes get a fibrin accumulation in the anterior chamber. And it doesn't seem to be in relationship to the peripheral iridectomy creation. It may be related to an allergy to the myocol or some other solution you put in the eye. But when you do have fibrin create in the anterior chamber, you can have a great degree of difficulty in unfolding the graft. And here you can see that there's fibrin there, and my graft unfolding was not complete. I have a D-shaped graft, and nonetheless, the patient did quite well, but it can be quite frustrating, especially if you're spending over 30 minutes trying to unfold your graft. And it's all due to the fibrin. Our solution to that problem is, prior to putting the tissue inside the eye, we go with an IA tip, and we then evacuate the anterior chamber and make sure that there's no fibrin in the anterior chamber. And if there is, you can evacuate it quickly with the IA and then quickly get your graft in, and it gives you a few more minutes of getting the graft unfolded, which is often all you need. Postoperatively, there's a dark side to DMEC as well. Graft separation issues are the one most encountered. Full separations come from upside-down grafts. I have not seen a graft be completely free-floating in the anterior chamber unless it was upside down. And now that we have an S stamp and we have other methods, confocal, we don't get upside-down grafts. Partial separation is very common. If it's more than 30%, we rebubble. And rebubbling is easy at the slit lamp. Let me show you a video where we make rebubbling so easy it doesn't interfere with your clinic. I'll show you, well, once again, graft separation total only when it's upside down. We have had a case where we had a patient that was lost to follow-up. We saw her one day, it looked good. She didn't come back at a week. She had some health problems and didn't come back for 6 months. And what you can see here is that the entire temporal side of her graft had separated and had become adherent. And even though she had this terrible looking OCT, the entire cornea was clear because it filled in with endothelium from the graft and from the recipient, and her vision was quite good. Now let me see if I can get that video going for you. Yes. So here's a novel technique we presented at ASCRS where you can easily do this. Now we simply take a cannula, attach it to a syringe. Now this syringe is attached via an extension tubing. So this ID extension tubing allows you now to use two hands at the slit lamp to do the rebubbling and also have exquisite focusing. Because you can see right here that I've got the syringe in my right hand and the joystick, and I have complete control of the cannula with my other hand resting on her eye, on her cheek, and I can completely control the slit lamp, the syringe, and the cannula, and we enter through the inferior paracentesis. I give it 1, 2, 3, and we
Okay, so how was that having our rebubble?
Unbelievably easy, no pain, and it was very quick.
Right. That didn't cost me very much money to have her say that. It truly was. It's amazing. We don't go to the minor operating room anymore. We do this at the slit lamp, and when it's set up, it's very quick and easy, and the patients really like it. So you can have rebubbles that are more frequent than DSEG, but you end up having an easy time of doing it. Pupillary block is one of the most feared complications of DMEC. This is a case of pupillary block at day 1, but I want to show you that peripheral iridectomies are important to me because this peripheral iridectomy I made down here prevented the patient from having a terrible problem. She had 350 degrees of angle closure, but the 10 degrees that was open was right here, and the pressure was only 18. What had happened was that the air bubble had gone behind the pupil and caused reverse pupillary block. But we simply released dilated the pupil, came forward, and it was released. This is an interesting case of pupillary block where this patient was perfect on day 1, on day 2, on day 3. But then when he started to absorb his gas bubble, it got small enough that when he went to the movie theater and his pupil dilated, the gas bubble passed through the pupil, and when he came out, the constriction occurred and he got also reverse pupillary block. We took him to the clinic and we removed some of the gas and he did fine. But it happened on day 4, so there can be problems. If the patients say, I have severe pain, you must listen to them. The other aspect of the dark side of DMEC is that you can get iris issues and posterior synechia formation when you have prolonged contact of air or gas with an inactive small pupil. So you do want to dilate your pupils postoperatively, and you also do not want to use pilocarpine or myostat because those constrict the pupil for a long time, and they can lead to posterior synechia formation. Usually not visually significant, but not nice to look at. We use Myocol or acetylcholine. This is a patient that described a second image. I'd never heard of this before, but The peripheral reductectomy in this phakic patient that we did initially was so large that she had a second image. We closed it with proline sutures and eliminated her problems with double image. And then finally, two last cases. A dark-sided DMEC is an anterior subcapsular cataract. I think we also heard this at this meeting, that the air bubble in a phakic patient can cause an anterior subcapsular cataract, usually not visually significant, but it can be. And then finally, we have the fear we always have of infection or epithelial ingrowth. And just like the SEC, you can get these white spots that occur in the interface, and you have to ask, is this Candida, most likely organism, or is this epithelium? And you can watch it, or you can go and remove it. And there's a lot of controversy on the best way to treat these type of problems. In summary, then, DMEC represents pure anatomic replacement surgery and unprecedented quality of vision for our patients. Like any surgery, there's a dark side that the surgeon must always be on guard against. And certainly as DMEC becomes more commonplace, we're always, all of us, going to have unique opportunities to really explore more of the dark side of DMEC. I'd like to thank my son Charlie, who's with me at this meeting, my son Nicholas, who was not able to come, and my lovely wife Cindy. I should mention that today is my 28th wedding anniversary, right today, here in Italy. So I'm very excited that we're in a romantic country to celebrate this. And I thank you very much for your